symptoms on the right arm. This is a one-level procedure. His shoulders are very wide, very thick. We've had a little bit of difficulty just getting our visualization down to where we want it, but we're actually there and we're ready to make our incision. So I've got my needle in position, my guide wire through the needle. I'm going to make a 4mm incision. This is on the patient's left side of his neck. I just injected a little bit of local medicine before we do the incision so that we can have some hemostasis and reduce any kind of pain or discomfort he'd have in his neck. So 4mm incision. Our guide wire is in position, anchored. And what I'm not happy with is really the angle that we're at. So I'm going to have to make an adjustment to that angle. All right. At this point, I'm going to remove the needle, leaving the guide wire. But I need a good shoulder pull. I need to make sure my team has good visualization. So before you do that, let me get the dilator, which I've got. And let's go ahead and give a good pull, inline traction. And we're going to take the needle out in just a moment. Shot. All right. Can you give me anything better than that? No? Yes, maybe so. I'm pulling the needle out. Shot. Guide wire is still in place. Yes. There's actually a bone spur. You can see it in front of this disc, C6-7. And we are at the C6-7 disc. All right. We have a 4mm incision. Guide wire is coming. Guide wire will be used to relocate the dilator down. Shot. Very good. We're making our way down to the disc. Nice and gentle. Shot. Very good. Close. Shot. All right, we're right at the front of the disc. Let's lighten up the image. Are we recording?
Yes.
Lighten up the image. I want to show where we are. Show me those vertebral bodies. Relax a little bit, Luis, just for a moment. Everybody relax for a moment. So 2, 3, 4, 5, 6, 7. We are at C6-7. Perfect. All right, relax everybody for a moment. Give me the coker, and we're going to do an AP. So I'm a little bit off on the patient's left, which is the side we're coming from, and we're aiming across the disc mostly to the right, but we're going to treat the entire disc herniation, left to right. Shot. All right, very good. So you can see that we're right in the middle of the spine. The tip of the dilator is resting on the anterior longitudinal ligament in the front of the disc, and it's literally a millimeter off the midline, if anything. There is a little bit of scoliosis, so hard to say, but I'm very happy with this. Let's go back to a lateral view, and I'm sorry everybody that you're going to have to work a little harder this morning than normal to try to get us the lateral view that we want. Just wait. Are we all ready? Let's go with a lateral. Oh, wait, slow down. She's not pulling. All right, shot. Let's see where we are. We don't want to move the patient. Okay, very good. That's a good view right there. Give me a second. I'm going to try to get my dilator into the disc space by just gently twisting and advancing it. Shot. Okay, we're making some progress. Shot. Everyone's doing great. Hang in there. Shot. Again, hard to see because the patient's shoulders are so big. All right, I'm taking this guide wire out. Give me the mallet. We're just entering the C6-7 disc from the front. Shot. Perfect. You guys are doing a phenomenal job. We're almost done. Shot. It is a nice disc. Shot. We're going to the back. It's perfect. Let's get the tube. You guys are doing great. Give me a second. I'm almost done. So we're going to do the whole surgery through this little tube. It's a 4mm wide tube. That's why the incision is only 4mm. Because that's all we need to do this endoscopic situation where the shot where there's a pinching between the tube and the dilator, and there's soft tissue in there, and it'll drag the dilator forward with the tube. You can see the tube is about mid-disc right now, and the dilator tip has not moved, which is perfect. Shot. 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 And it's just nice little taps, nice little advances, maybe a millimeter here, a millimeter there. I don't want to go too much too far. You have to be patient. Shot. Just about there. Let me see, let me feel it. So I like to wiggle it a little. He's got a pretty stiff C6-7 disc. Shot. And I can feel it moving at about a millimeter, maybe. Half a millimeter sometimes. And you just want to be really careful not to advance the dilator tip. So I'm just about there. Shot, feel it right now. I'm at the back of the disc. So I'm going to do one more verification x-ray before I take everything out. All right, now everybody get ready. We're going to do one last verification x-ray. Everyone's in position? All right, ready, set, let's do it. Shot. Hey, that looks perfect. I don't think it could be any better. I'm really happy. All right, so we're going to take the dilator out, and we're basically, yeah, we're in the back of the disc. Nice job, Luis. Yep, we're good. All right. So what I can tell you right now is that this is a herniated disc at C6-7 with some degeneration of the disc from chronic inflammation due to the annular tear in the back of the disc. We're going to go in there and repair this disc with the Deuk laser disc repair. To do that, we're starting all the way at the back where the tear is. We're going to do a debridement with the laser of the tear, and we're going to remove all the little pieces of herniated disc that are down there. All right? And we're literally the right side. So our target is to make sure we unpinch both nerves on both sides, but really our primary focus is the right side, because that's where the patient's radicular symptoms are. All right, I need some help here. I need to get these cables on the other side of the tube. Let's get those over. Now, I can feel, as a surgeon doing this for so many years, I can feel there's no movement of this disc, none. This disc is scarred down. Literally, the inflammation at the back of the disc where the annular tear is has been going on for so long that this disc is not moving anymore. He's lost the movement. When I'm done with this surgery, you'll see there will be a few degrees of movement. So this surgery, the Deuk laser disc repair, is the only surgery that actually restores movement to discs. And you can see that restored endoscopically every single time. All right, let's get started. So our laser fiber is there. It's the blue thing with a little glass tip at the end. I want to position it so that I can see it at all times. And there's a little piece of disc material there, and we're gonna get started. How's our patient doing? All right. One thing we didn't get to do was much of a discogram, and the reason for that, let me get those pieces, was because the angle that I had to get the needle into this disc space from the front, that angle was very steep, pointing into the end plate of C7. So I wasn't able to inject dye, and that happens sometimes, either when the disc is so scarred up or when the angle of attack is so bad. But that's all we had. That was the best we could do. All right, Diego, why don't you show our audience why herniated discs and bulging discs, which are really the same thing, there's no difference between a herniated disc and a bulging disc.
Disc herniations are a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. the laser removes the herniation and debrides the annular tear. The annular tear heals on its own. It can take up to 12 months. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.
Okay, Dr. Deuk back with you. As you can see, the laser, which is at 12 o'clock on your screen, through that round little window. That round window is the actual tube that's sitting inside the disc. And you can see now we're starting to get some movement of the bones and the disc itself. Now, we had zero movement when I started, but while you were watching that animation, learning about how herniated discs cause inflammation and pain, I was busy creating basically our first section of debridement of the annular tear, and it's very badly scarred here. And you can already see the bones starting to move. So we already have some movement back at the disc, probably half a degree, if I had to guess, which is really not much. But by the time we're done, we'll get a degree or two of movement. So Deuk laser disc repair, you hear about fusion takes movement away. ACDF fusion takes movement away, okay? Artificial discs preserve movement. Whatever movement you have, they preserve it. They don't give you more movement, they just preserve what you have. So if you don't have any, there's a herniation. If you don't have any movement, when the surgeon starts the surgery, you're not going to have movement at the end of the surgery. So fusions take movement away, artificial discs preserve movement. Deuk laser disc repair is the only surgery that restores movement, that gives you back movement that you don't have. So why do I get so excited about this surgery? Well, obviously for a lot of reasons. One, it's natural. We're not putting metal in the patient's neck. Number two, we're actually restoring movement that wasn't there at the start of the surgery at the disc without putting a metal disc in, okay? And number three, we're taking the patient's pain away. This surgery removes, on average, 98% of people's pain in their neck. That's an average number for all of our patients that have it. And it takes away headaches from the disc that herniates. This patient doesn't really have headaches. We call those headaches that come from the neck a cervicogenic headache. By the way, that's the end plate. See that at 3 o'clock, that weird like kind of line? That's the back of the vertebral body of C6, and it's on my right because I'm facing Luis, who's on the patient's right. And then the end plate of C7 is right here, and there's a little bone spur there, that gold thing. Anyway, there's herniations I've already been taking out, zapping with the lasers right here. And just underneath this mess of scar tissue from the annular tear, just underneath this is the spinal cord and the nerve root, which we don't want to get into. But there's actually some bone spurs right here in the foramen that I'm getting rid of with the laser. All right, let's run our second animation video, the one that shows the crowd what we do with the laser, how Deuk laser disc repair actually works. This is a revolutionary surgery.
Disc herniations are a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear.
See the grabber, how it works? It grabs, and it's really skinny, so it goes all the way down the hole. So I freed up a herniation with a laser that was stuck to the annular tear in the back of the disc. I went down, I felt it, and I grabbed it and pulled it out. And And there it is right there. All right? Right there is a nice chunk of herniation right at the back of this disc. Now, based on the MRI, I can tell you there's a lot of those back there because this disc was badly damaged. The whole back of the disc is herniated. Which way was I going with it? Yeah. So I feel like we're going to see more of those fragments of herniation soon, okay, as we work. The red is blood, in case you didn't know. This is a living, breathing patient, so they bleed when they get, surgery, just like everybody does. But this amount of bleeding we get with this surgery is about, 1 or 2 drops of blood versus ACDF or artificial disc where you're going to get a lot more bleeding. So this is almost a bloodless surgery when you compare it to other types of surgery. All right, Diego, any questions from our audience?
No questions as of yet.
All right. For those of you wondering about the surgery, I've done about 1,000, almost 1,400 of these surgeries in my career of endoscopic spine surgery like this. And the surgery is very safe for the most part. We've had one complication in basically 15 years of doing it. And, that's a very low complication rate. So it's much lower than open surgery. But it just, it's a very good complication rate. So, all right, so I've worked my way towards the patient's left side, and I'm going to turn my camera, my endoscope around and go back towards the right side because I kind of work back and forth. And as I do that, I'm removing herniation. Like here's another piece of herniation right there. You can see it, It's just wiggling around, wants to come out. And it's just a slow process of using the laser to debride the annular tear and release the fragments of herniation. Now normally the way we do this with an anterior cervical discectomy or fusion is there's another herniation right there. We would be scraping this stuff out with like a little shaver called a curette or a drill. Wow, there's another fragment right there. Can you guys see this? Let's get the light on.
Yeah, we can see it.
So, you see that? Another piece.
Yes.
And like I said, this patient's going to have a lot of these because his whole disc is pretty badly damaged. But that doesn't mean it needs fusion. It doesn't. That's the whole point. We're not fusing. We're not putting a cage or an artificial disc. This is all natural. Why don't you hear about this surgery more? Because the truth is that the companies that make the screws and rods and plates, they don't want you to know about this surgery because they're not making money on this surgery. They're not putting metal in your body, so they don't want people to get this surgery. They don't want surgeons even knowing about it. They've done a really good job of hiding this type of endoscopic spine surgery from the public and also from academic centers where surgeons are trained. I wasn't trained to do this surgery at my residency in neurosurgery. I had to learn from the Koreans in South Korea and the German surgeon how to do it. And they didn't teach me the Deuk laser disc repair, obviously. They taught me the basic endoscopic surgery approach, which was the needle and the guide wire and the incision and the tube. But it was myself who developed the annular debridement, which is the hallmark of this procedure. And that's because they honestly don't understand the source of pain for people's neck is actually the actual tear in the back of the disc. So nobody really cares about the tear or pays attention to it. When I say nobody, I mean doctors. They don't understand how important the annular tear is in the generation of neck pain and headaches and arm symptoms. Most arm symptoms people get from a herniated disc, like pain down the arm, numbness in the hand, tingling, weakness. It's actually not from compression of the nerve root, it's from irritation of the nerve root. Okay, why am I, there we go. And it's the irritation of the nerve root that causes those symptoms more than compression. Well, we're back at the bottom here of the tube. I have to be careful not to push on the actual endoscope because that will release the glue between the fibers, and then what's going to happen is the fiber optic cables, there's I think 5,000 of them in the scope, they will come unsealed, and then you get a blurry picture, which eventually happens anyway with fiber optic endoscopes. They eventually need to have their fibers resealed, but you can see the amount of movement we're getting now, and the bones are actually moving about 1 degree. Which there was no movement before because the end plates were scarred together from chronic inflammation and all the scar tissue that comes with it. So, quite interesting. Another piece of herniation there. So these fragments of herniation that you're seeing pop into view, they're located just to the side of the tube. Remember, the tube is just in one specific place, but the herniation is across the entire back of the disc. So as we move the tube side to side, left to right, we start to encounter these fragments of herniation that are just outside the tube, and they slip underneath where I've removed the other herniations. They now pop into view. So you have to take your time to remove them, otherwise you're not going to have a good surgical result. All right. Any questions from our audience?
We have one question from YouTube. What is the standard recovery time for this procedure?
Standard recovery time is 1 hour, and then people go home. So 1 hour recovery, go home. You cannot drive a car or operate machinery the same day as the surgery because the patients have general anesthesia. Our patient is asleep. Maybe you can't see it under the drapes, but there's a tube down into his lungs, ventilating him on a ventilator. That's what the anesthesiologist does. And so he's completely out and asleep. And he's also what we call chemically paralyzed, where we give him a neuromuscular blocker that stops his body from moving during the surgery. So all that general anesthesia and neuromuscular blockade, all that medication takes about 12 hours to wear off. So by the next day, patients are awake and normal. But to be discharged, it's 1 hour from the surgery center. It's outpatient surgery. This patient goes home today. I've done these surgeries now for 15 years, and every single patient goes home the same day. Good question. All right, so I'm moving back and forth along the back of this disc. You can see we've removed a good amount of herniation. We're probably maybe halfway done. I think if I had to guess by now. It's hard for me to see outside the tubes to know exactly how much is left, but I feel we've gotten 50% of the material fixed and removed, and I'm just working to go out towards the foramen right now. I have to advance the laser a little bit so I can reach a little further. Yeah, I would say we're 15 minutes out from being done. Great questions, by the way. Sometimes you got to pull the tube back a little bit, like I'm doing right now, to get further to the side. I do that quite often. And our patient has big shoulders, so I've got to work around the big shoulders. You know what would be nice, Luis? Is a scope that has a light source that actually angles back so it doesn't hit the shoulder. You know what I mean? How's our irrigation? Good?
We
These
have
are
another
all
question.
little pieces of herniation were floating out, by the way. What were you going to say?
We have another question.
Sure.
How long will the patient be in a neck brace?
How long will the patient be in a neck brace? 6 weeks. 6 weeks is standard for all these patients that have spine surgery with us, whether it's a fusion or a laser surgery. 6 weeks in a brace. Whew, another herniation. Everything good on the irrigation? Thank you. Oh yeah. I'm sorry? I believe we're okay, yeah, I see. I just want to make sure I can float these guys out. That's why I need that pressure. The pumps are nice, huh? Yeah. No more $70 bags, Luis. Yeah, I know. We may have to buy another pump just to make sure. They're what, 1,000 mils? So what are you saying, you want 3,000? Oh, so we can get a 3,000? I don't know if there are 3. Well, so what are you suggesting? The next ones we buy are 3,000s? Yeah, but I don't know that they even make a 3,000 liter pump. That's the thing. They do? Oh, we have a 3,000. Oh, so we bought a 1,000, tested it, it didn't work well because it ran out of irrigation. Got it. All right, so if you're going to buy another one, we need a 3,000. Okay. I don't mind having another one on standby. You know me, I'm a big believer in redundancy. Yeah. All right, any other questions, Diego? We're just about done. Probably 5 minutes now. We've gotten out a lot. I just want to make sure we got out everything we need to. Okay, let's switch sides. All right, Diego, any questions?
No more.
All right. Why don't we talk about the difference between Deuk laser disc repair surgery, what you're watching now, versus a fusion surgery that you'll be offered by another surgeon.
Okay.
Deuk
now.
Let's let our audience see the difference.
Yeah, I'm playing it right now.
A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, 2 patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a ½ inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before released to go home. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's 1/2 inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery. The Deuk laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Deuk Spine Institute. With the highest published success rate of 95%,
Disc herniations are a common cause of chronic neck
the
pain.
most successful and least damaging spinal surgery.
Animation video to learn about the difference between fusion and laser endoscopic Deuk laser disc repair. You can see that fusion is far more invasive and risky with the metal implants. People don't want it, but when your surgeon only knows how to do fusion, you're going to be recommended for a fusion. So you need a surgeon that can do both endoscopic and fusions. All right, we're just finishing up here, and I'm in the right foramen. And I've zapped away a lot of herniated disc. You can see the annular tear I've debrided, just wrapping up the last of it. As gold color is bone spurs and calcium deposits in the foraminal ligament. All right, going to move back to the other side, hopefully for the last time. Take out any other herniation fragments we find, like this one. We're going to be finished in just another minute or two. So if you have questions, feel free to write them up for me, and I'll do my best to answer them. But you can see we're at the limit of the annular tear. A lot of scar tissue back here. And that was all scar tissue there at the back of the disc. I've removed what I can safely. Below that is going to be the spinal cord. There's no more herniation back here. What is that? It's like an air bubble. That's the posterior longitudinal ligament. Let's just go peek one more time. What happens is as I move my tube around, more of the annular tear fibers and herniated discs can move into view. This is a big one. Let's see. I may have to come down on top of this. Yeah, it's huge. And you can see that there's some pink tissue in it. That's your granulation tissue from chronic inflammation. All right, I thought I would be done quicker, but it's not. There's just too much herniation back here, guys. And that's fine. So I need a few more minutes. All right, that is a giant piece of disc herniation. See that? It's all calcified. It just shot down in there.
Hey Doc,
Yeah,
we have a question from our app.
sure. From where?
The app.
Okay, good.
What is the impact of multiple herniations? Can the disc heal after the surgery, or do you have to heal the tear?
There's no way to heal the tear. All I'm doing is cleaning the tear so that it'll heal on its own, okay? The tear is there because of trauma to the disc. This patient injured his disc at some point, causing trauma to the wall that holds the jelly in. And that trauma is called an annular tear. And basically, through the annular tear went the jelly from the center of the disc. It literally just pushed out. Once the wall's down, the jelly just leaks out when under pressure. The whole purpose of the wall is to keep the jelly from leaking out under pressure. So, no, we're not done. So when when you bend or lift, what keeps your bones from rubbing on each other, your vertebrae from rubbing on each other, is a cushion between them. And the cushion has two parts. It's got a wall, and then in the middle it's got this jelly. And it's really the jelly that keeps the bones from rubbing on each other and wearing each other down. It's like a washer. But what keeps the jelly there is the wall, the annular tear. So once the wall has a tear in it, now the jelly can leak out, okay? And that's what's happening in the herniated disc situation. That's what's happening. So what we're doing is we're going in and the wall tries to heal itself, but it can't, because in those torn wall fibers is the jelly, and the jelly blocks the healing. Okay, think about it as a cage full of wild pigs, right? The cage opens, the door opens, the wild pigs start leaving the cage. And then one of the pigs gets stuck where the door closes and it can't close, so the cage stays open and the pigs just leave. If you've ever seen, if you know what I'm talking about, there are these wild boar that run around the plains in the United States and destroy farms. So farmers trap them in cages because they always go together in packs. Anyway, if one of those boars gets stuck in the entrance where the cage closes, then the cage door cannot close back. And those animals will just keep coming out, escaping. And that's what's happening with the herniation. Once the tear happens and the jelly squeezes through the tear cannot heal properly because the jelly is sitting there. Okay? And the tear tries to heal through a process called inflammation, where it sees the jelly stuck in the tear as a foreign body, and it sends the inflammatory system in to attack that jelly so that it can heal and close. But there's so much jelly there that even though you inflame it and tack it, it just doesn't get rid of it because there's too much, just by sheer size and volume. You can see these pieces here. They're massive. So you just end up having this pain in your neck or back that goes on for years and years and years because you keep, the inflammation keeps going, attacking that jelly that's stuck in the tear. And then you re-injure your disc, you do something like play sports or golf, and then you push more jelly out through the tear that's already there, okay? So it's a vicious cycle of injury, herniation, injury to the tear, injury to the annulus fibrosus, herniation, and re-injury, and the pain never goes away because the nuclear material just sits there and causes pain constantly. Here's a piece of herniation. I'm trying to grab it out, but I can't. It's just not coming out. So I have to blast it with the laser and vaporize it into little pieces. But you can see it's literally yellow because of calcium. So that's an old herniation that's been there for years. And the body's inflammatory system attacks it and tries to get rid of it, but that process of getting rid of it doesn't really work because it's so big, so much mass. So what happens instead is it gets smooth on the surface where the inflammation was attacking it, kind of like a river stone gets smoothed out on the surface from the effects of the rolling around in the river against other stones and the effect of water on the surface, just attacking the surface, smoothing it out, getting rid of all the rough pieces. And then also you get calcium deposits on it. So what we were about to end, and then we had a huge herniation just present itself into the field from the patient's right, and I've been literally breaking it up. It's like an asteroid that I'm trying to get the whole thing out, but it won't come out. So I have to break it up into little pieces. So I'm just hitting it with a laser, trying to fragment it. Oh, there. That thing is a big bug. See if I can get it. It's finally moved into view. Remember, I've got a small little working area that I can see through, and I'm trying to pull all these bigger herniations out through that small tube, and they're bigger than the tube, so they don't want to come out. So I have to use the laser to blast them into pieces. It's like mining, you know? And they're calcified. That's what all that gold stuff is you're seeing. It looks like sunlight on there. It's not. I'm literally having to amputate pieces off. Come on. And float them out. And then go back and attack it again. So I'm doing pretty much what the human body is doing. Trying to break down this herniation with my laser. And the patient's body was trying to do that for years and didn't succeed. But look how fast I'm doing it. So basically what I'm doing is I'm doing what your body naturally does, but I'm speeding up the process. Come on. Instead of it being, 50 years, fuck it. I'm doing it in 50 minutes. That makes sense? It's pretty cool stuff. And when you do an anterior cervical discectomy and fusion, you're also going in and removing these herniations. But the problem with ACDF is that they're not repairing the annular tear. They're not debriding the annular tear. So that's why a lot of people still have problems after ACDF. Plus, they don't do all the discs they're supposed to do. Let's go. I need more pressure, maybe? I don't know. These little fragments don't want to float out. All right. Grab her. It's fucking a waste of time. And yes, I discovered this whole process here at Deuk Spine. That's why you can't see this surgery done anywhere else. Number one, they won't broadcast it, even if they did it. And number two, it was pioneered here. So you won't find it elsewhere. Okay, just about done. Once again, really this time. Promises, promises. All right, I'm trying to get off to the right side, make sure I get all these pieces of herniation. Great questions so far from our audience. Any others?
We have one comment on Facebook saying that they feel a lot of the similar pains on their upper and lower back.
Okay. Well, come to Deuk Spine and we'll fix you.
And they also say that traditional fusion surgery is not healing.
Is not what?
Healing.
I honestly couldn't hear the comment.
Traditional fusion surgery is not healing.
No, it's not healing.
Mhm.
It's removing, destroying. It's destructive. This is a healing procedure. We're not putting any metal or fusion or artificial disc. We're just repairing the disc, doing what the body has been trying to do for a long time for this particular patient with their herniation. All right, that's it. Looks like we have another visitor on this other side. All right, doctor, I really think 5 minutes at this point. If I could just... And the problem, we're struggling a little bit with positioning of the scope, folks, because the patient, number one, we're doing C6-7, which is the bottom disc in the neck. It's really hard to get to surgically for any kind of surgeon, whether you're doing a fusion or artificial disc, whatever, it's hard to get to. It's so low. And number two, this patient has a higher collarbone than normal, so we're struggling to get access to the disc. And his shoulders are huge. He's a big man, like muscular, big, beefy shoulders. So those shoulders are keeping us from being able to visualize down lower. So this was a really challenging one to get to, and he continues to challenge me throughout the surgery, not just getting into the disc, but also fixing it. And I don't blame him, obviously, but the reality is that those physical attributes of the patient, short neck, high collarbone, big shoulders, they make the surgery a lot harder. All right, just trying to wrap up, and I know I keep saying 5 minutes, but the truth is that from what I'm seeing, it looks like 5 minutes, but then I'm getting in here and fighting with this thing, and it's putting up a big fight, you know, with me. Look at all this scar tissue from inflammation, for years and years of inflammation. All of that. Now, of course, I'm not trying to remove scar tissue. That's not my goal. My goal is to remove the herniation, the nucleus material. But the problem is sometimes it's locked into the scar tissue, like literally embedded. So you don't know if you're leaving any unless you remove the majority of the scar tissue. Because you don't want to leave the nuclear material. That's just going to create more inflammation over time. And it'll be back where you started. So the goal is to get rid of all the herniation, but not take the scar tissue, but you're going to have to take some scar tissue to get all the herniation, because the herniation is locked into the scar tissue. So I feel pretty comfortable that I got it all here. And the way I know that is I'm looking for the posterior longitudinal ligament fibers, and I'm seeing them. And most herniations don't penetrate the PLL. They're subligamentous, we call it, below the ligament on the disc side, which is where we are. All right, I feel pretty good about that. We're pretty much done. We're done. See, this time I told the truth. That was a long one. Scope off. Great job. I'm sorry it took so long, but it's not my fault. It's the patient's fault. All right, little antiseptic. Never had an infection or with these surgeries. We used to use an antiseptic called bacitracin in our irrigation, but then it became unpopular a couple of years ago because some people were injecting them, not here, but elsewhere. They were injecting that medicine into the muscles, and patients were getting complications. We call it neurotoxicity. And so they kind of took it off the market and made it impossible for us to find. It was the best medication to use during surgery to prevent gram-positive cocci from infecting the patient's wound. All right, we're done. I want to show you the whole surgery was done through this tube. Okay? Can you all see this here?
Yes, we can see it.
See that little tube? It's like a straw, a McDonald's shake straw. Hey, Luis, I need that back actually. The little fluid adapter to get the tube out. Because it grabs onto the tube in such a way it helps me take it out. It just keeps popping off. Yeah, his disc was pretty collapsed. He had a pretty severely degenerated disc at C6-7, but we still were able to fix it, and I probably gave him back a degree of movement, 1 degree, which is not a lot, you know, most people don't talk about a degree, but it gave him what he didn't have. I restored movement. Okay, so again, fusion takes away movement. Artificial disc preserve movement, supposedly, but they really don't. And then Deuk laser disc repair restores movement, because I'm removing all that scar tissue in the back that holds the bones together and keeps them from moving. And by removing all that scar tissue, it releases the vertebrae to start moving relative to each other. A lot of people don't realize there's 2 types of fusion. There's hard fusions, which is a real fusion between bones, and then there are what are called soft fusions. And soft fusions are scar tissue holding bones together so they don't move. So when you talk about fusion surgery being done with implants, a lot of times you don't get a hard fusion, you get soft fusions with the scar tissue. Well, that's what this patient has. And it's not from surgery. The soft fusion here is from, you ready? It's from inflammation, soft fusing the bones. So I just went in there and freed up all that scar tissue, so it freed up the bones to start moving. So Deuk laser disc repair is the only surgery in the world that actually restores movement to a herniated disc. All right, great job everyone. I'm going to call the blood loss 1 mil, about 1 milliliter. So this was a DLDR, left approach, C6-7. Folks, if you have questions, write them up online, and I'll be happy to come over there and talk to you and answer them, okay? Why don't you run my my spine scans exposed, talking about implants and fusion. The one you just
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, 2 patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a ½ inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before release to go home. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's half-inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself, whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement, whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery. The Deuk laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Deuk Spine Institute. With the highest published success rate of 95%, the Deuk laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged discs causing back pain, neck pain, sciatica, and radiculopathy due to herniated, degenerated, or bulging discs.
Hello, for those that are still tuned in, Dr. Deuk is on his way. He will be here very soon. Thank you so much for waiting. Coffee?
Yeah.
All right, we'll be live in 3, 2.
Thank you, Deb. Dr. Deukmedjian here, wrapping up the Deuk laser disc repair surgery we just completed on a patient who traveled from Seattle, Washington, across the country, from the northwest to the southeast here in Florida, where Deuk Spine Institute is located. And he came here because, number one, he had a herniated disc at C6-7, which we just fixed.
Okay.
Are we good?
Yeah, no, we're
All right. And just to understand better what a herniated disc is, our spine, which is located deep inside our body, it runs from the bottom of the skull down to the tailbone, is made up of vertebrae or bones that look like this. And these bones right here in this segment, we call it a segment of the spine, which is 2 vertebrae with the joint between them, which is the disc between the vertebral bodies, and then the facet joints in the back, along with the associated nerves. This segment is actually a motion segment. It moves, and normally the bones move about 3 degrees in rotation and a couple of degrees, like 3 or 4 degrees in flexion extension and lateral bending. So it depends on the part of the spine. If you're in the lumbar versus cervical, the movement is a little bit different. But this is pretty much what we're dealing with. And the most common injury to the spine, by far, is an injury to this cushion between the bones. It's called the disc. And we call disc injuries, depending on the stage that they're in, we have a different name for them. So when the disc injury first happens, it's called an annular tear. And the annular tear means that the wall here on the outside that holds this jelly in the middle, that wall tears, okay? And we call that an annular tear. Just to give you an idea, I'm going to take one of those cushions out, flip it up, so you can look at it better. Here's the front of the disc, here's the back of the disc, here's the sides. Now, the wall is made up of a very tough material called collagen and a little bit of elastin. Now, if you've ever eaten steak, you have that meat that you eat, and then there's a really tough rind around it that most people don't eat. We cut it off and, give it to the dogs, throw it away. That rind is called the annulus fibrosus, and it's really strong, tough, made out of collagen, mostly in elastin. Whereas the jelly in the center is mostly water and something called hyaluronic acid, basically glycoproteins that are in there. They bind water, they hold water, and they're jelly, okay? So the jelly sits in the middle, and throughout the day, as you get around and you bend forward, sideways, picking things up, lifting things, bending, twisting, whatever you do with your body, your head, those bones move, and as you lift things and bend, they compress down on each other. And so that you don't have bones smashing into each other, they have this cushion between them called the disc, okay? And the jelly in the center is really what cushions the bones, but you got to hold the jelly there, otherwise it'll squeeze out the first time you move. So to hold it in, you got a wall called the annulus fibrosus. All disc injuries begin with a tear in the annulus fibrosus. Now, this concept is foreign to most doctors today in 2021. They have no clue that the initial injury to a disc is always an annular tear. The annular tear can be in the front, the sides, or the back of the disc. It's the annular tears in the back of the disc that cause pain, neck pain, back pain, thoracic pain. The reason for that is that the nerves that go here in the back of the disc, they go to a special place in your brain called the primary somatosensory cortex. And that part of your brain understands where the signal comes from relative to the entire body. And it gives or associates that specific pain that comes from this area in the back of the disc with the lower back, or in the case of this patient, the neck. So this patient has neck pain because the little nerve fibers in the back of the disc are sending signals to that part of his brain saying, hey, we have pain in the neck. Now, had the tear occurred on the sides or the front, those signals don't make it to that part of the brain called the primary somatosensory cortex. They go to other areas that are non-specific. They cause non-specific pain. You're not even aware of it. It doesn't make it to your cortical level. You're not consciously aware of it. So to get pain that really hurts and it feels like it's in my neck, it's in my back, what really localized where you can put your finger on it, you have to have a tear in the back. That's step one. And then the jelly from the center, you bend and it puts pressure on that jelly between the bones, squeezing it. It shoves the jelly out through the tear, okay? And we call that the herniation. So the act of the annular tear first, ripping of the wall, it causes like pain for a split second, but you don't get that chronic pain from an annular tear. You get pain when you lift something and your bones come together and push the jelly into the tear on that injured disc. And then the jelly wedges in there like you saw today in this case, and that creates inflammation in the back of the disc, and the inflammation is painful, and that's why you feel it. In your brain, it says, hey, my neck is hurting. Who discovered this whole pathway? I did, okay? Which is why I have to teach it to you, because you're not going to learn it anywhere else, not in this year. When did I discover it? I discovered it in around 2007, 2006, 2007. So we're talking about 24 years ago, okay? 15 years ago. My math is not so good today. So about 15 years ago, I figured this out doing endoscopic surgery, just like the surgery you saw today. And I saw the results in the patient, and it made sense. I started to put it all together with my knowledge of neuroanatomy. I'm a neuroanatomist. Neurosurgeons study neuroanatomy. I'm a neurosurgeon. We study neuroanatomy, but I was a neuroanatomist before I became a neurosurgeon. And I probably have never mentioned this in any of my broadcasts, but there is a neuroanatomy competition in Los Angeles every year at the Children's Hospital of Los Angeles. It's called the Retzius, named after a Swedish neuroanatomist. He was famous many years ago, like 120 years ago, and he would dissect the brain and he would look at all the nuclei and the axons and neurons and figure out where things are going. And his name was Gustav Retzius, okay? And to pay a tribute to this great neuroanatomist, the Swedish neuroanatomist, Dr. Floyd Gillis, the head of pediatric neurology at Children's Hospital of Los Angeles, would hold an annual neuroanatomy contest called the Retzius Neuroanatomy Contest. And neuroanatomists from all over the world would fly into Los Angeles for this contest. Neurosurgeons would come, neurologists would come, neuroradiologists would come, and they would administer a test of 50 questions with different areas of the brain and spinal cord and nerves being pointed at. What's this? Where does this go to? Where are the fibers project from this nucleus? Where does this nucleus receive input from? And I'm the winner of the neuroanatomy contest, the Retzius contest, back in 1996, okay, 1996. That's before I became a neurosurgeon. And I had the highest score on the test that they have ever had. I missed one question. I had a 49 out of 50. The next person was a neuroradiologist, and he scored in the around 33, just to give you an idea, 33 out of 50. That's how hard the test is. And then the top neurosurgeon at USC that year, Arun Amar, Arun scored just below that guy, somewhere around 30 out of 50. So he missed 20 questions. Am I bragging? No. But what I'm trying to tell you is facts. These are facts. This is history. This is what happened. So my understanding of neuroanatomy is really good, which is why I understand why back and neck pain come from an annular tear in the back of the disc, because the fibers that innervate the back of the annulus are called somatic afferent nerve fibers, and they project specifically to the somatosensory cortex, which is why you feel sharp pain. Now, what's the big deal? Well, the big deal is, unfortunately, most doctors have no clue that this pathway exists. They don't understand it. So they're not treating pain properly in the spine. They don't treat back or neck pain properly. They give you pills to cover it up because they don't know the source of it. But I figured out the source of it using my neuroanatomy background and understanding. And our surgeries now, the Deuk laser disc repair, specifically targets this one little area in the back of that one painful disc or two painful discs. In the case of this patient, it was one painful disc. I realized through my understanding of neuroanatomy and studying my patients' disease with herniated discs and fixing them for years, I realized that this tear right here is the source of all the back and neck pain. It's called the annular tear, and it's because the herniated disc is sitting in that annular tear causing pain and inflammation. It's causing inflammation, which is causing pain, okay? So what I do is I go in there and I went in through the front and I used a laser to clean up this tear and remove the herniation. And that's what we just did. It's called the Deuk laser disc repair. It's named after me because I'm the pioneer who discovered it, the whole procedure, okay? So let's get to the questions.
Okay, cool. So we have our first question. He says that you do all the best for the patient and your doctor and your team, but he has a tough question. What does the patient have to do first to take care of their spine and their hips?
All right, thank you for asking the question. Somebody is saying, what does the patient have to do first to take care of their spine and hips? I'm not sure I understand the question, so I may answer it wrong. I believe what you're asking me is, how do you prevent having an injury to the spine or the hips? Maybe. So how do you prevent injuries to the spine? The answer is avoid trauma. I know it's simplistic, but it's true. All of these herniated discs come from trauma, okay? I saw, for the first time in my career, a 2-year-old child, who had been diagnosed with herniated discs. Now, I'll be honest with you. I've not seen too many MRIs of 2-year-old children. Very, very few. Probably less than 5 in my career of 26 years of doing this. And I can't say for sure that the discs were herniated, but maybe they were. We're going to find out probably in a couple of years when we repeat the MRI. But I can tell you this. I have seen 12-year-olds, 13, 14, and 15-year-olds. And I've seen their MRIs of their backs, and they can have a herniated disc at 12, 13, 14-year-old, probably younger. I have seen degenerated discs with the disc is collapsed, which means that there was a herniation, an annular tear or herniation that had been there for a while, and that inflammation was going on, destroying the disc over time. And now you have a degenerated disc with the bones on bone. And that happens in kids. So traumatic injuries to the spine can happen in childhood and can result in herniations that are painful. And I've treated them. I've actually operated on a 15-year-old girl who was a semi-professional skier in California, and her father could not get any relief for her. None of the doctors in California. He's a famous lawyer, big-time lawyer, and money wasn't the issue. Power, money, he knew everybody, and nobody helped his daughter. I mean, they tried, physical therapy, pills, shots, nothing worked. She had a herniated disc. It was a small one. It was a small tear and a small herniation at 0.45. I saw it on the MRI. I said, that's where your pain's coming from, that tear. And he said, go ahead and do the surgery. So we did it. Her pain went away immediately after surgery, 100%. 15-year-old girl, athlete, and nailed the source. She had a 1-level Deuk laser disc repair. I can't remember if it was right or left side, but I went in and repaired that disc, just like I do all the others. And her pain went away 100%. Okay, so young people get injuries to their discs, and they have pain from it. So please, this is why we do the broadcast. These people shouldn't be suffering needlessly. In other words, they're ignored. They're not believed. People don't believe them. So the problem is, number one, 12-year-old, 14-year-old girl comes in, I got back pain. the first thing they say is it's menstrual, it's related to your cramping and whatever. But it's not. It's actually from a herniated disc. But they don't make the diagnosis. They just kind of and ha and send her out, you know, take this and that medicine, come back if it still hurts. They come back, then they say, okay, maybe it's muscular, let's send you to therapy, but it's not muscular, it's a herniated disc. So they send that person a therapy. They do therapy for 3 months, 6 months. The pain's still there. It's not any better because therapy doesn't fix pain from a herniated disc. So now this person has been bumped around the system. They don't have a proper diagnosis. They've been misdiagnosed multiple times and mistreated. It's really mistreating, okay? And because she hasn't had the right treatment, she's got a herniated disc, simple thing to fix with the laser surgery. Because the doctors are ignorant, because the doctors have their head up their ass, they have no clue what's going on, and all they do is they do pills and therapy, okay? So these people suffer. And here's the thing that's the worst. Remember I told you the tear happens, the jelly gets pushed into the tear, then you get inflammation in the disc? That causes pain, right? But that's not the worst of it. That pain is from inflammation, and that inflammation is your body attacking that area. Well, as your body's attacking it, it's destroying the joint. Your own body's inflammation is destroying the disc, and that's where degenerative disc disease comes from. Degenerative disc disease is simply the same thing, an annular tear with herniation. It's a herniated disc that over time destroys the entire disc. And you have all these famous scientists spending hundreds of millions of dollars in research funds going, we don't understand why discs degenerate. We don't understand degenerative disc disease. You have all this research going on. Oh, we see that in degenerative disc disease, there's a destruction of the matrix proteins of the nucleus pulposus. Of course there is. They're being attacked by the inflammatory system. We see in degenerative disc disease, there's inflammatory cytokines, okay? Interleukins, tissue necrosis factor. Of course it is, because it's an inflammatory process, you moron. So these guys are spending hundreds of millions of dollars, scratching their heads and sitting there and spinning around in a circle trying to figure out what causes degenerative disc disease. The answer is obvious. It's an annular tear with the nuclear material that promotes inflammation stuck in the tear, causing a massive inflammatory reaction. And by the way, the same thing happens in your knee. The same thing happens in your shoulder. When you injure your knee with a meniscus tear or your shoulder, the inflammation in that meniscus tear just goes on and on and on if it's untreated, and it destroys your knee, and then you need a total knee replacement. That's what happens. It's basically a misdiagnosis and mistreatment. That's what we're dealing with. There's only one surgery in the world that fixes an annular tear. That is the Deuk laser disc repair. You just watched it. I'm the only surgeon in the world that does it. I'm the only surgeon in the world that discovered it, and I'm the only one who's published it. It's in National Library of Medicine. I published it in 2012, okay? So I'm trying to get the word out. Now we're broadcasting live all of our surgeries. We want the world to know the truth, because your doctors, your public leaders, your government, your politicians, your health insurance company, nobody is telling you the truth. And that's why we have to get the message out, because it is the truth. And people need to know the truth. If your doctors won't help give you the truth, I need to. That's what we're trying to do with these broadcasts. Next question.
All right, we have a viewer that says thank you for the stream. She is from Buffalo, New York, and the surgery is not offered there. She says she just finished watching the spinal fusion comparison video, and just looking at all the pain and trauma makes her sick. She says thank you and God bless.
Thank you from Buffalo. I appreciate the comment. It means a lot that you're out there and you understand what we're trying to do to educate people about the truth. If you watched my fusion surgery, yeah, I was a big fusion surgeon. Big, I mean huge, monster fusion surgeon. They say that 90% of spine surgery is done by 10% of the surgeons, okay? And I believe that, it's true. There are about 10% of us that are really good at doing spine surgery, really good at doing contemporary spine surgery like fusions, because it is complex spine surgery. It requires special skills and an understanding of the instruments to put the implants in, as well as the implants. And I've put in literally 10,000 plus, maybe 15,000 screws, rods, cages, neck, lower back, thoracic. And that's all I had, okay? And I took a lot of pride in the fact that compared to other spine surgeons around the country, this is back in 2004, 2005, 2006. We're talking about 15 years ago. When I got out of my training, I was trained very well. I thought fusion was the best thing in the world since sliced bread. And it was, okay? Because it was a tool that we had as spine surgeons that could cure pain. That people were suffering with back and neck pain, I could cure it. Pinched nerves, I could cure it with a fusion, all right? But after a few years of doing this, I encountered somebody who told me, have you ever done laser spine surgery? And I laughed at them and I said, there's no such thing. And he said, no, there really is. Now, he didn't tell me it worked or not, but he said there is, and it's done with a little tube. And I'm like, I've never heard of that, you know? I don't believe it. So after talking to my wife, and I credit my wife because she's the one who got me to go look at it, I watched the surgery. And like I've said before, the most important thing, the patient survived and there was like no complication from the surgery. So right away I was like, wow, that's very different. That's a small incision, a lot smaller than anything I'm doing. And there was no metal put in the patient, you know, and excuse me, that was during the surgery. So you don't really know if the surgery works or not until later. But I was visiting, so I didn't have a chance to follow up with the patient, see if it worked, because it wasn't my patient. But just the fact that the surgery was done and that they survived and there was no complication and it was done in a way that I've never seen done before, endoscopically, I was like really impressed, to be honest. And so with that, I went and took the initiative to learn how to do these surgeries. Let me call you back. And so I went overseas and I trained to do the surgeries and with Koreans and German surgeons that were starting to do it, and brought it back to the States, and then trained more with an orthopedic surgeon named Dr. Anthony Young. So he was my greatest mentor. Now, Dr. Young taught me to do lower back surgery. He didn't do necks, he didn't do thoracic, he never did. So I had to pretty much develop that technique on my own, doing the anterior cervical, which is what we did today. And honestly, what sold me was the results, okay, in my patients. Like the elimination of pain. The fact that I could cure neck pain and back pain with this surgery was impressive for me, because I knew I could cure neck and back pain with screws and rods, no problem. I did it. I've done it hundreds and hundreds of times at that point. But to cure neck and back pain without screws and rods, then I started really thinking, like, how does that work? I mean, I thought that I was stopping movement that was painful at the joints, and that's why fusion works so well, was stopping painful movement at the disc or facets. Now, when I started doing laser surgery, I was only treating the disc, not the facets. And so I started getting results that were equal to fusion, where the pain was gone, but the recovery was 1 hour rather than, 2 months, 3 months. And there were no need for narcotic painkillers. Of course, in the beginning, I gave narcotics because I didn't know any better. I thought, well, it's still painful. The patients need narcotics. But once I modified my technique a little more, I was able to do the surgery delicately without damaging anything in the body, and the need for narcotics was zero. So now we're on, anti-inflammatory, basically Tylenol. So yeah, the results of the surgery being as good as my fusion surgeries, which is complete elimination of pain, by the way, with no recovery, with no post-op pain meds, and no complications. It was incredible. I mean, I knew that this was going to change the world. In the same way that we used to take pictures with SLR cameras and develop film with chemicals, and everybody did that. You took your roll of film out when you were done, you sent it off to Kodak, and they had your pictures for you in 3 days. You go pick them up, right? And then I saw a digital camera, the Nikon Coolpix. That was the first one that came out. I bought one, started shooting pictures with it, and then put a connection to my computer. And next thing you know, on my laptop, I had those pictures. I said, this is going to change the world. This is it. I mean, there's no going back. Same thing with the cell phone. Once the cell phone was created, compared to you know, people who live long enough, they know you used to walk around the street and you used to see, you know, phone, like pay phones. You put 50 cents in and make a phone call. And they were everywhere, pay phones. And people had these phones in their houses. So this technology with the endoscope was so powerful, so transformative and amazing with the results and the no downtime and no complications, that it literally rocked my fusion world to where I started transitioning more and more patients to endoscopic because they wanted it and they could afford to do it at the time. So we got away from fusions, and now I went from doing hundreds of fusions a year to doing less than probably 10 fusions a year on the spine and still treating as many patients. So yeah, this endoscopic surgery is quite amazing. And but in the end, to answer the question, avoid trauma to your body, avoid injuring the discs. Just be smart, you know, don't be a fail army candidate with your actions. People do a lot of crazy things. They jump off roofs, they, you know, ride quads into trees, and there's a lot of stuff that goes on out there, and that's how you injure your spine. So the only way to prevent a disc injury is to avoid trauma to your spine. I don't know if that answers the question, but if it didn't, just ask a question again in a different way.
That's all, man.
That's all the questions we had. So thanks for hanging out with us. I'm Dr. Ara Deukmedjian, the CEO and founder of Deuk Spine Institute here near Orlando, Florida. And hope you enjoyed the surgery. Hope you learned something about it. We have another 2 surgeries today. So pop some popcorn, get your chestnuts roasting, and fill up your Diet Coke once again. If you're not familiar with our app, we have a Deuk Spine Institute app. It's free. It's available to you to download. Download it to your phone or your computer, and you can use it to gain access to really good information. You can even ask questions through the app. Also, we have a Facebook support group that you can go on to. It's open to everyone to join, but it's obviously, we limit membership to just people who aren't trying to, you know, sell you something that's not beneficial to you. So apply to join our Facebook support group. It's called Spine Surgery Support Group. Spine Surgery Support Group. And yeah, have a great day. Thanks for watching.